And
about getting to that habit and see why they did
I want to get back.
If I could ask people to take their seats. I'm the director of the Bureau of Community Health and Prevention at the Department of Public Health. And I have the honor this morning of both welcoming you to the Ounce of Prevention Conference and opening the conference. It is really exciting to be with everyone here today. This, as you all know, the Ounce of Prevention has brought together, well, all of you, people across the Commonwealth who are working to create healthier and more equitable communities. There are almost 400 people in this room today. And all of you back in your communities are working to address this very topic. So thank you very much for taking time out of that important work to be with us here today to talk about this important topic and get some ideas and strategies for taking back to your communities. Lots of you probably are aware that we have in the past held the Ounce of Prevention Conference in the fall, but partly in consultation with our public health colleagues, we decided this year to hold it in the spring. I hope you feel as we do, that after the long winter that we have endured, it's particularly nice to gather together in the spring. But possibly more importantly than that, this week is National Public Health Week, and it is a really great opportunity to spend part of that Public Health Week together with our public health colleagues from across the Commonwealth. And to add to that serendipity, April is also National Minority Health Month, and the department is particularly proud to be hosting the Ounce of Prevention Conference during both National Public Health Week and Minority Health Month. The theme of this year's conference, working together to create healthier and more equitable communities, is perfectly situated in the midst of these two important national recognition periods. So one of the real pleasures of today's conference is that we are joined by Dr. Monica Burrell, who is here at the Ounce of Prevention Conference for her first time in her role as our new Commissioner of Public Health. We welcomed Dr. Burrell to the department in February, and she is going to be providing some opening remarks shortly, and I'm sure you are all as looking forward to that as I am. We're of course also honored and really excited to have with us today Dr. Adewale Troutman as our keynote speaker. As many of you are aware, Dr. Troutman is a leading public health voice promoting health equity, racial equity, and the importance of the social determinants of health. I had an amazing hour this morning having breakfast with Dr. Troutman and a number of other public health activists and experts from across the state. It was an amazing conversation, and I can't wait to hear his keynote. I am sure that he will inspire us all to continue to do this important work. He's truly an amazing thinker, and I'm really looking forward to hearing more from him this morning. As you can probably tell from the agenda, the Planning Committee has been very thoughtful in selecting topics and in planning today's entire agenda. It was a collaborative effort, and I want to thank very much the Bureau of Community Health and Prevention. There were a number of staff from our Bureau, as well as the Bureau of Substance Abuse Services, the Bureau of Environmental Health, the Office of Health Equity, the Office of Health Planning. They all worked very hard in pulling together today's conference, but I particularly want to acknowledge a couple of folks. Leah Susan Oyama, who many of you know is our Director of the Division of Prevention and Wellness. Leah Susan. All of her hard work and leadership in convening the Planning Committee, amongst a number of roles she plays at the Department of Public Health, and of course Georgia Simpson-May, who is our Director of Health, and Kathy O'Connor from the Office of Health. So you may have noticed, if you've been again at the Ounce of Prevention Conference before that we've done things a little bit differently this year. In addition to the new time of year that we're all meeting, it's a new location, and we purposely chose to do fewer workshops, but are offering those workshops a couple of times so that you all have a chance to attend the workshops of your choice. But please let us know how this new structure is working out for you by filling out your evaluation form. So it is now my true honor to introduce Commissioner Monica Burrell, who is going to provide us some introductory remarks. You'll find a full background of Commissioner Burrell in your packets, but just to note, she became, as I said, our commissioner in February of this year. As commissioner, she's responsible for spearheading the state's response to the opioid crisis, as well as leading the department's implementation of healthcare cost containment, which we call in this state Chapter 224. She also has a focus on reducing health disparities, finding public health solutions for healthcare reform, and finding innovative solutions using data and evidence-based practices. Dr. Burrell comes to the department widely recognized for her dedication to healthcare for underserved and vulnerable populations. She previously served as the Chief Medical Officer of Boston Healthcare for the Homeless Program, the largest nonprofit healthcare organization for homeless individuals in the entire country. Dr. Burrell has served on the faculty of Harvard Medical School, Boston University Medical School, and Harvard School of Public Health. She was previously at Boston General Hospital, at Massachusetts General Hospital and Boston Medical Center. She's practiced general internal medicine for 20 years in neighborhood health centers, city hospitals, the Veterans Administration, university hospitals, and nonprofit organizations. Please join me in welcoming Commissioner Monica Burrell.
Hi everyone, good morning. Good morning. Thanks for being here. I feel like I'm with a room full of friends. There are many, many familiar faces in the room. I've done projects with many of you, and we are the face and the voice of public health. So just by you being here, I can tell that I know that you're committed to public health and improving public health. So thank you for being here. And Carlene, thank you for that introduction. So here we are, it's 2015 at the Ounce of Prevention Conference. And our theme for today is working together to create healthier and more equitable communities. So healthier and equitable, let's focus on that. I know looking across this room that you're all committed to healthier and more equitable communities. And as we talk about, so it's National Public Health Week as well, and I want to focus on this piece about equity for a little while. So, in addition to the National Public Health Week, many of you know that each day there's a theme, and today's theme is starting from zip. So starting from zip is about zip codes. And as many of you know, unfortunately in America today, your zip code says too much about your health. Zip code matters much more than it should. Because as we know, place matters. I know this firsthand from my clinical experience. Carlene told you about my work at Boston Healthcare for the Homeless. I've worked with vulnerable populations for the last 2 decades, and working on the front lines with vulnerable and underserved populations, I can tell you that it takes a lot of work to provide the care with the dignity that our fellow citizens deserve. From the street corners, to the park benches, to makeshift structures underneath bridges and on the sides of tunnels of our great cities of Massachusetts, people live in abysmal circumstances that are beyond challenging. Beyond challenging, and much less with very little hope for maintaining dignity and basic human hope. So if you're an individual who, and it can happen to any of us, has the unfortunate luck of dealing with homelessness and then having diabetes, how do you possibly maintain your treatment for your diabetes? How do you prevent, we're here for prevention, the complications of diabetes? How do you get enough to eat? How do you get enough of the right food to eat? Because you know what to eat, but where do you find it? How do you get it? How do you afford it? How do you take your medications? How do you store insulin without a refrigerator? Get transportation to vital medical appointments, and so on. I give you this extreme example of our brothers and sisters who live with homelessness because place matters and zip code matters. And today we focus on health and equitable communities, but that's a healthy and equitable community for all of us. So we know that the circumstances in which we're born, life's lottery, right? Or we grow up, or we live, work, and age, are strong predictors of overall health status. And as a doctor, I found myself counseling people on eating well, exercising, not smoking. But how hard is it for us to follow these recommendations? We need to recognize, and I know the people in this room do, that there's a complex web of social and environmental factors that affect everyone's health and limit the ability for many people to make healthy choices. And as we know, place does matter. We know that poverty is the root to many health disparities. Recently, the dean of the BU School of Public Health shared a study with me looking at disparities by T-stops. So I know we're in Worcester, but I'm going to get Boston-centric just for an example. So the Dudley T-stop on the Silver Line is a healthy 2-mile walk to the Arlington stop on the Green Line in Boston. It's really close. 2 miles is nothing, unless it's snowing 16 inches. So looking at those 2 T-stops, we know that 32% of families, 32% of families who get off at the Dudley T-stop live below the poverty line. And in Arlington, that's 4%. 2 miles, 32% versus 4%. 2 miles in one of the greatest cities, in one of the best states in the country. And then what follows is we know that when you're getting off at the Dudley stop versus the Arlington stop, the rate of diabetes is 4 times higher, 4 times higher. And then what follows naturally? Rates of premature death, preventable premature death, are double if you're getting off at the Dudley stop than at the Arlington stop. What does this tell us in this example of one of the finest cities in the world with arguably the best medical care in the world? Within those 2 miles, I can't tell you how many fine hospitals there are. But you look at these disparities. So these numbers really are what should get us to roll our sleeves up, get ready for the day ahead, the months ahead, the years ahead, to work together, because these numbers are not acceptable. Place matters more than it should when it comes to health and equity. So if we don't want zip code to be the strongest predictors of health, then we need to make sure that we understand pieces of data like this. We don't have enough information. We don't have enough data to be able to manage populations and to do so-called hotspotting, to find the individuals that we need to find to provide the limited resources that we have. We have a lot more work to do in making sure we have the data we need to address these disparities and make sure that everybody lives a long and healthy and productive life. Now, as Carleen mentioned, in addition to being the National Public Health Week, it's the National Minority Health Month. And the theme for the National Minority Health Month, which you'll hear more about later as well, is 30 years of advancing health equity, the Heckler Report, a force for ending health disparities in America. This theme was chosen by the U.S. Department of Health and Services to mark the 30th anniversary of the report by the Secretary's Task Force on Black and Minority Health. And just as a reminder, because it's so important, but I know many of you know, this groundbreaking report was released in 1985 under the leadership of the former HHS Secretary Margaret Heckler. If you can believe it, this report marked the first convening of a group of health experts by the U.S. government, the first to conduct a comprehensive study of racial and ethnic minority health, and it elevated minority health to the national stage. This milestone anniversary serves as a paramount opportunity. Let's take this opportunity now to highlight there's been a lot of work at the national and local level towards eliminating health disparities and advancing health equity. For example, there's been legislative or policy action that's effective and can be effective. Examples include the Affordable Care Act, the HHS Action Plan to reduce racial and ethnic health disparities, and the National Partnership for Action to End Homeless Disparities. But we all know that our work is far from done. There are hundreds of studies that link racism to worse health. Some examples include breast cancer, heart disease, hypertension, diabetes. We have a lot more work to do together. To me, any discussion of disparities must start with data so that we have a sound foundation to know where we are, so we know where we need to make improvements. We must do a better job at collecting data that identifies important trends in health and in our important subpopulations who live in poverty as well as underrepresented minorities. So what can and should DPH do? We are working to advance data collection and reporting to better identify and document populations experiencing disparities. To give you some examples, we're working with local health departments to develop guidance and methods to better reach low vaccinated populations. We've developed issue-specific programs, such as the Comprehensive Cancer Control Program, which seeks to identify promising practices to reduce disparities through community efforts on the ground. And through our work with the Prevention and Wellness Trust, we're coordinating closely to develop healthy communities through community and clinical linkages with a focus on the integration of culturally competent community health workers. Together, through our collective efforts, we can accelerate this momentum towards achieving a nation free of disparities in health and healthcare. We're so happy today to have you're so lucky to have one of the leading experts, Dr. Adewale Troutman, who you'll be hearing from later, who's a national leader in addressing health disparities. Later on in the afternoon, Georgia Simpson May, our Director of Health Equity at the department, will continue this theme, and I hope you join her for that discussion. I'm sorry I can't spend the day here. I really wish I could. But I'm really glad that you're all here today. This is such an important event, and we really appreciate your support at being here, because I know that means health matters to you as well. And I leave you with this. If a measure of a good society really is how we treat the most vulnerable among us, how we treat the most vulnerable among us. So if we're measuring our society, the greatness of our society, by how we treat the most vulnerable among us, and if our goal is healthier and more equitable communities, then we have a lot of work to do together. And I look forward to the discussions today, as well as working with you all in the near future. Thank you all for being here.
Thank you so much, Commissioner. We have now come to the time in our agenda that's pretty fun, when we will recognize some of the really, truly extraordinary work that is taking place across the Commonwealth to create healthier and more equitable communities. I'm thrilled to join the Commissioner as we present first the Commissioner's Leadership Award, and then the Peter R. Lee Healthy Communities Award. It is never easy to select just one award recipient from a pool that has lots of really deserving nominations, but we did. And so Commissioner Burrell is going to be presenting our first award.
So the Commissioner's Leadership Award recognizes exceptional leadership in promoting healthy and more equitable communities. This award acknowledges and celebrates the extraordinary work of an individual in convening multiple partners to work together for healthier communities. I'm so pleased to award the 2015 Commissioner's Leadership Award to Albus Bershevkin of Northern Berkshire Community Coalition. About you now, next to you. So come on. So Al founded the Northern Berkshire Berkshire Community Coalition in 1986 to improve the quality of life for residents of Northern Berkshire County by organizing, supporting, and empowering the community. He has provided the leadership needed to build and sustain the coalition, and Al has led efforts to bring and retain many resources to Berkshire County. The many programs Al has introduced and sustained are diverse and far-reaching across the community. He has demonstrated long-term commitment towards improvement of communities' health, and through this award, Al is recognized for his nearly 3 decades of leadership of the Northern Berkshire Community Coalition and dedication to improving the health of those in Northern Berkshires. Please join me in honoring Al Vershevkin as the recipient of the 2015 Community.
I have a mic. I want to thank you for recognizing me, and even more, thanks for recognizing our rural region in Northern Berkshire. I'm honored and pretty humbled by this award, and no, if not for the wonderful folks that I work with at the Coalition, and I'd like you to stand up right now so you can see a few of them. This could not happen. No way I could do what they do. And I'm blessed to be around so many wonderful thinkers. One size doesn't fit all. And I want to applaud the Department of Public Health for recognizing that. I want to thank those staff of the Department of Public Health who share our vision of what can happen in a rural area, have made the trek all the way out to North Adams, because it's important to be in our rural area, to know our rural area, and I want to thank all of those folks for doing what they've done to make us a stronger region. And I want to thank you, Commissioner, for this award. Thank you very much.
Honors a coalition or partnership for their collaborative work in creating healthier and more equitable communities. Leah Susan Oyama is going to be giving this award.
Thank you, Carly. This award is named for Peter Lee, and like many of you in this room, I knew and worked with Peter for a long period of time, and I think it's always hard to come to this conference without Peter here, but I know he is here in spirit. So Peter was the late director of the Massachusetts Partnership for Healthy Communities at Health Resources in Action, and was a leader in the Healthy Communities movement in Massachusetts and across the country before his death on December 25th, 2012. He personified the principles of healthy communities in his professional and personal life and was a longtime participant and organizer of the Ounce of Prevention Conference. The Juvenile Advocacy Group is the 2015 recipient of the Peter R. Lee Healthy Communities Award. With over 50 member organizations from the communities of Milford, Bellingham, Hopedale, Mendon, and Upton, as well as regional and statewide organizations, JAG, as they are known, so it's an easier thing for me to keep saying, represents a strong multi-sector collaboration focusing on the reduction of underage drinking and substance abuse, promoting positive behaviors, and improving health outcomes. JAG strives to meet the community's needs, particularly through youth engagement in their initiatives. Ongoing collaboration between the youth and adult JAG members has created opportunities for community engagement to improve overall health. The collaboration has led to the creation of a youth council and the recognition that including the youth voice and addressing the needs of youth is critical to success. Please join me in honoring the Juvenile Advocacy Group as the recipient of the 2015 Peter Lee Healthy Communities Award. Amy Leone and Jen Ward are here today representing JAG.
We just wanted to thank you all for the nomination for this award. Peter Lee, we went to the Mass Forum, starting with him many years ago when the Juvenile Advocacy Group started. And over the last 8-9 years, we have really found that there is no magic in the success that we have done in the community. And the key that we have found is being very authentic and being true to ourselves and being honest and compassionate and driven to do the right thing for the youth and the families in our area. And sometimes that means for us, what we've learned is to listen more than to speak. And sometimes that means that when we're approached with some of the difficult adversities in our community, that we have to learn to say that I don't know, but I can find out. And today, getting this award isn't an award for myself or Jen. It is really an award for the community and all the members of JAG, because we have realized that the definition of power is the ability to produce an effect. And I hope that all of our members of JAG and everybody here can recognize that every one of us has the power to affect change every single day. And that is what we're all doing. And we kind of look at this and we look at the changes that we've made in the greater Milford area as dropping a pebble in the water. And that causes that ripple that grows and it spreads. And that is the same thing that we do every day in the work that Jen does and Ellen does, and all the collaboration that we do in the community, is we are just causing that ripple effect to make sustainable change throughout the greater Milford area. So I just want to thank you very much for this award.
So I'm sure you are now all thinking that we're ready to move to our keynote, since we've presented our 2 awards. But I'm going to ask you to wait just a bit longer to hear from Dr. Troutman, because we have a surprise recognition. I'm sure that when many of you think of the Department of Public Health, when you think of healthy communities for sure, and when you think about the Ounce of Prevention Conference, one name comes to mind: Kathy O'Connor. You know that after more than 20 years, in fact 23 years at the Department of Public Health, Kathy's retiring this spring. Dr. Troutman repeated that about 3 or 4 times while we were having breakfast, just to remind us so that we couldn't be in denial about it any longer. So we couldn't let today go by without recognizing Kathy's leadership and thanking her for all she has done to create healthier communities in the Commonwealth. Kathy, can you join us on stage?
Says it all. The Massachusetts Department of Public Health recognizes Kathy O'Connor for her more than 2 decades of leadership in creating healthier communities across the Commonwealth. Thank you.
So this really is a surprise, and for once in my life, I actually am speechless. But yesterday was my birthday, and I can't think of a better gift than to be here today, to be able to share a farewell with all of you in this venue, because this is the way that we've always worked together on healthy communities and prevention, and so this really means the world to me, and you all are a gift to me.
So excited! Apologize. And that really was a very special thing for many of us here at the department. So now I'm going to invite up Georgia Simpson-May, the director of our Office of Health Equity at the department, to introduce our most esteemed keynote speaker.
Good morning, everyone.
Good morning.
And thank you, Carlene. And I really want to stand up here and almost shout, because whom I'm about to introduce to you is like a rock star to me. So really excited, really. So I am so pleased to have this opportunity to introduce our keynote speaker this morning. I have been on the planning committee for today's conference, and when I was asked to make a suggestion for a speaker aligned with our theme, Well, yeah, Dr. Adewale Troutman immediately came to mind. Not only is he a leading public health voice promoting health equity and the importance of the social determinants of health, but also someone, as I said earlier, I wanted to meet. So I have a wish come true today. I am so glad I have had that opportunity and that you will hear from him, as I have watched most of his work on some documentaries, and that you'll also hear about. Adewale Troutman identifies himself through his commitment to social justice, human rights, community activism, health equity, and national and global health. His life's work has been a testimony to this fact. Dr. Troutman has over 40 years of dedication through action to the principles of universal freedoms and the elimination of racism, injustice, and oppression. His unique educational background has been a major factor in this quest. Dr. Troutman has an MD from New Jersey Medical School, a master's in public health from Columbia University, master's in Black Studies from the State University of New York in Albany, and as of October 2009, board certification from the National Board of Public Health Examiners. He is a residency-trained family physician graduating from residency at the Medical University of South Carolina. His career has included clinical emergency medicine, hospital administration, academic, and public health practice. Dr. Troutman is featured in the nationally televised and award-winning PBS series Unnatural Causes: Is Inequality Making Us Sick? Dr. Troutman serves as a member or past member of the National Board of Public Health Examiners, the Academy for Health Equity, the Health and Human Services Secretary's Advisory Committee on Health Promotion, Disease Prevention, Healthy People 2020, the Health and Human Services Advisory Committee on Infant Mortality, the Board of Directors of Public Health Law and Policy, the Executive Board of the American Public Health Association, the African American Heritage Center, and the National Association of County and City Health Officials, and oh yes, Dr. Troutman serves as past president of the American Public Health Association. As has been noted earlier today, April is National Minority Health Month and serves as an opportunity to highlight national and local efforts towards eliminating health disparities and advancing health equity. So how fortunate are we to have Dr. Troutman with us to not only discuss but share his insights and his wisdom for creating a health equity movement. Please join me in welcoming Dr. Adewale Troutman.
Good morning, everyone. Good morning. I'm speechless. And, you know, one of the things I judge as I travel around the country is what rooms feel like. You can get a sense of what the room feels like by the people who are in it and their beliefs and their practices. And this feels like a really good space. It feels good to be here. I'm very relaxed. Thank you. I certainly wanted to thank a few individuals that we've had the pleasure of meeting. And Jackie, where'd you go? She sat down. I wanted to thank her again. To thank Liz from the Department of Public Health, and of course Barbara Ferreira, who is not here, but a good friend of mine who really showed the power of courage in stepping out beyond the line and saying what needed to be said to bring into existence the discussion about racism and institutionalized racism throughout the society and its relationship to health. Of course, as has been pointed out, this is Public Health Week, so it's a double honor for me to be here this week, and it is Minority Health Month, so it makes it a triple honor for me to be here, to be a part of this session today, to talk about some very important issues. You've heard an introduction. I always like to make sure I let you know a little bit more about who I am by virtue of taking a look at. And I think you're trying to figure out which one is me, right? I'm not going to tell you. You have to guess that. But a little more about me. That I was actually born in the South Bronx, New York City. I have two brothers, and my mother raised all of us after my father left when I was about 4 years old. So we were really poor. We were so poor that we couldn't afford the OR on the end, so we would just poke. It was a difficult time to grow up as a kid. The 60s and 70s, I always talked to my wife about traveling down to Virginia with my mother in the car and stopping at Howard Johnson's and needing to go in and take a restroom break and walking up to the door and seeing a sign across both door sides of the door, facilities for white only, which as a 16-year-old kid from the Bronx, I said, we're going in there. And my mother said, no, hell no, we're not. so we went back. But my mother recently had some medical challenges. She had some syncope, passing out episodes. And I thought it was probably time to talk about a assisted living facility for her to go into. She initially said yes, and then after a minute said, you know what, I don't think I need it anymore because Preston comes to the house now 4 or 5 times a week. Preston, my mother's 97. And Preston is 78. So she said, I don't need to go anyplace anymore because Preston's coming in every day and taking care of me, so we now call her the original cougar. So this has been referenced already, but I'm a strong believer in the fact that this is about the power of one. You know, I came through an educational system in New York City. I came through a system where the junior high school guidance counselor told me that I should be an auto mechanic. And the senior guidance counselor told me that I should forget about college. I wasn't college material. I came through that system believing ultimately that there's power to change the world, and that I had that power as a matter of fact. And one of the things I strongly believe in is the power of one. Some of the people that we recognize as having made tremendous achievements as individuals, but connected to the public and the important issues of the day. Of course, you think of Martin Luther King and Malcolm X right away, and Angela Davis, Steve Jobs, who changed the whole way we communicate throughout the world. Nelson Mandela, who recently passed on, Harvey Milk, and his efforts in the gay community, and so many others. Oprah Winfrey, we all know about Oprah, and you. So in the room, the power of one is represented by every one of you. And when we talk about creating a movement, I remember in the 60s, whenever the word movement came up, this was the response. Raise your fist. So we think that it's time for us to stand together in a movement and say, raise your fist. We don't think that we can do things, that we don't have enough strength, power, influence, whatever. Particularly when we look at some of the influences and some of the things we're trying to work on and say, that's just too much for me to handle. But when you think about what one person has done in many, many situations, like some of the names on the screen, there's no reason why that shouldn't be you. You remember Tiananmen Square, when the young man stood in front of a tank and caused the tank to move. And when the tank moved, he moved. And the tank moved the other way. That example is absolutely, it's kind of envisioned in my head constantly. And you can be that person. The power of one is in this room. And remember, if you haven't seen the names and the pictures, this is a relationship with these 2 slides to say what these people look like. Who are they? You can see on the screen. There's Malcolm X, there's Nelson Mandela in the very middle, Angela Davis, who some of us forget sometimes, Mahatma Gandhi, Rosa Parks, and there's a space in the middle there where it's blue and empty. That's where we want to put you. So next time I go someplace, I want to put the slide up and I want one of you, maybe you, to be on this slide. And I can say, right there in Massachusetts and Boston, here's another magnificent individual who's shown what one person can do. That's good? And we are, in fact, all connected. In public health, we know that. There's so many examples of that, but I chose to talk about the great philosopher, Mufasa, who famously said, we are all connected by the great circle of life. That's my CNN voice. I'm waiting for James Earl Jones. Just to get us on the same page. And I know this is a very sophisticated audience, and we know we have definitions, we know what things are. But I find from time to time it helps just to remind us of the concepts that we're talking about when we get back to basics. The first, of course, is the definition of health itself. And what I would remind you of is that this definition doesn't say health care. It says the definition of health is physical, psychological, social, economic, and spiritual well-being, not merely the absence of disease or infirmity. So by definition, we're talking about all of these different forces that have an impact on the community health. By saying the word health, that's what we're talking about. Also, it's the maintenance of a harmonious balance between mind, body, and spirit. And I'm forcing myself to slow down in my speech because I have a tendency to be, as a New Yorker, I have a tendency to talk too fast. And then I don't want to do that. I want to be just conversation with you because it's really important to me. We had this conversation about the definition of the word equity. By the way, we did a fantastic conversation over breakfast this morning. It was just absolutely invigorating, and I thank our organizers for inviting us to breakfast today. Equity, this is more than just a destination. It's more than a process. Some people say equity is a process, some say it's a destination. It's a new way, a different way of looking at the world. It's a way that creates a visionary opportunity for us to be about equity, about being the same, about having no one looked down upon, no one locked out of the system of anything because they happen to be Latino, African American, Native American, speak a different language, look a different way, have a different sexual orientation. Equity says that is bogus and it's not who we are. We're about justice and equity across the board. So look, when we talk about equity, we're talking about this broad concept, this highly effective vision of a new world and a new us. And we can be the progenitors of that by deciding that's who we are. And that's what the world's all about, and that's what we're going to be. Arriving at health equity, when you look at these terms that are listed, valuing all individuals and populations equally, focused and ongoing societal efforts, assuring the conditions for optimal health, addressing historical and contemporary injustices and socioeconomic disadvantages. So it's all there, just to grab a hold of that and see that that's who we are and that's what we're going to be. The powerful piece on this is also looking at health inequity, the flip side of what we now call health disparities. And one of my beliefs is that it's time for us to evolve into the next level of this work. Inequity, and inequity, as you see, is systemic, avoidable, unfair, and unjust differences. Not just differences, but systemic, avoidable, unfair, and unjust. That are sustained over time and generations beyond the control of individuals and population-based. Which does not let individuals off the hook, by the way. We should never think that as well. Individuals have a role here. But societal forces are critically important in determining what happens to populations and individuals. And if we miss that point, we will never get to a place where we close the gap in excess death, which is what Minority Health Month was all about. Thank you. And then we get to justice and social justice. WHO talks about the distribution of wealth, power, advantage, and resources, and finding a way to address that inequity if we're ever going to bring about equity in this world. It's a very tough call, but one we have to take a look at. I think the synonyms for social justice are very revealing. You see fair play, honesty, righteousness, morality, objectivity, neutrality, those are the things that are made up in the concept of justice. And justice, raising the level to the broadest level of society is what social justice is all about. The Hector report, which was referenced, I think was a real critical publication. Came out in 1985, as was referenced to, and it was in fact also the first time that there was a single location of data on communities of color. At that time, they were called Black and minority health, and those communities had never been addressed as a single unit. If you wanted information on cancer in the Black community, you had to go to the cancer literature. You wanted something on diabetes in the Latino community, you had to go to the diabetes literature. The Hector report put them all together. If you've never seen it, it's like 9 volumes. Really. There were 6 causes of excess death identified in the Hector report. HIV and AIDS was not included at the time because of the 1985 publication. You have to look at data from the early 80s. There's this executive summary, 6 volumes, and then a cross-cutting issue summary. So it's a tremendous volume of work that's still available to you, by the way, if you want to take a look at it. It helped to move us forward to addressing health disparities, all language, nationally, and is certainly critical. This report led to the creation of Office of Minority Health, all over the United States. It led to increased focus by the CDC. It led to funding by NIH, which had not existed before. So this is a very important and influential piece. But now we're 30 years later, and what does it look like? Well, part of the conversation is a reframing discussion, which we still have not completed. The first part of that is recognizing that we're looking at health, not healthcare. Healthcare is a small part of the spectrum that we call health. Healthcare is hospitals, clinics, doctors, nurses, diagnosis, management, treatment, diseases, so on, cost containment. Health, as the broader notion, is the things that influence the health populations: transportation, occupation, education, income, racism, discrimination, lack of access, and so on and so on and so forth. So this is what we're looking at, folks. When we talk about our work, we're talking about this. Healthcare is a part of it, but this is what we ultimately have to get to. That's a reframe that we need. Clearly, we're talking about population health, not individual health here. And then creating health equity versus limiting health disparities. The notion that disparities by itself just means differences. So there are some disparities that are based upon the fact that I'm a 69-year-old guy, and there's a 22-year-old young lady right there in the dark hair, brown hair. That's right. 22, aren't you? Yeah. There are certain disparities between the two of us just because of our age and gender. So using inequities makes it very clear what we're talking about. We're not just talking about differences, those based upon the things that we talked about a few minutes ago. And this is an issue of rights, not privileges. And one of the quotes that comes home for me is this one that says, ensuring access to quality, affordable healthcare services is not merely a matter of system reform, although that's a major part of what we have to do. It's a matter of human dignity and of national wellness. This is my classmate in medical school. And one of the things that he paraphrased is that doing the same thing in the same way and expecting a different result is insanity. So he would look at what we've been doing around trying to close the gap through the medical model, through individual attention, through a little more screening in the certain neighborhoods. He would look at that as insanity because the gap in excess death is still there. And although it's closed in some areas, it's still widening in others. So it means something different needs to be done if we're not to continue along this path of demonstrating what he would call insanity by doing the same thing and expecting a different result. Therefore, the change is to what we call the social determinants of health. And this is the metaphor that we were talking about a few minutes ago. If you've never seen this one, this is a representation of the metaphor that I think is critically important. So I want you to imagine that there are people standing on the bank of this river, and they're all fishing, having a very productive afternoon. And as they're doing that, a baby floats down the river. And they're shocked and awed by this, and before they can do anything, a second baby floats down the river, and the first one actually dies. So first guy throws his fishing rod down and dives into the water to save the babies. Then there's someone else on the side who says, well, let's not save them, let's just educate them. Kind of let them hang out in their own new environment, but educate them, maybe teach them to swim, or just kind of the dog paddle or something. The next person is an institution that really doesn't care. They're more concerned about the profit mind. Can I make any money by pulling these kids out of the water? If not, then the hell with them, let them stay in there. Then there's the guy who doesn't do anything, just stands around with his hands in his pockets and just continues to fishing. But one person throws his fishing rod down and turns and starts running upstream. And the other one call out to him and say, yo, dude, where are you going? We need you down here to pull some of these babies out. And he says, I'm going upstream to find out who's throwing the babies in the river and stop them. That's where we are. That's who we are. That's who we need to be. We need to be up there in the upstream and finding out what are the causes of all the downstream babies in the river. Those babies represent, by virtue of the study that I did with Dr. Satcher, over 83,000 African Americans per year who die in excess. Add to that Latinos, Native Americans, Pacific Islanders, Native Hawaiians, sexual orientation, issues of gender and disability, which we now know are all issues of inequity. We have no idea how many people die every year in excess that should not die because of the things that are killing them, which are based upon societal access and other issues like race and discrimination, etc. That's the criticality of what's downstream. Upstream, rivers upstream. tell you where upstream is. Upstream, we find differences in socioeconomic status, neighborhood, place, racism and discrimination, addiction, child development issues, stress, social gradient. They're all a part of the upstream discussion that we need to have. The social determinants, as a definition, is the complex, integrated, and overlapping social structures and economic systems that are responsible for both health and equities. The challenge becomes when we look at those upstream causes, that they are sometimes look overwhelming to us, and we feel there's nothing we can do to handle that, but we have to find a way to work on it together. Oh, there's my list, I'm sorry. You'll notice that food security is on there, the built environment, stress and social gradient are probably two of the most important on this slide. I talk about the racial relationship between where you are on the social ladder and what your health status is in relationship between the two. And wherever you are on the ladder determines what your health outcome is, and that should not be. So our response in Louisville, amongst other things, was to create the Center for Health Equity. It in fact became the first center in the local health department in the United States. And we did not create this center to be another location for health education and access to flyers and whatever. We created this center to be about systems change in the community of Louisville, advocacy, capacity building, and educating the populations on how to change the system. And some of the things that we did, I'll share with you just a few. Excuse me. We actually did community hearings that we called health equity community hearings to get community input on critical issues that we're facing them. Retraining the workforce, I'm going to go on, that's a very important aspect of the work that we were successfully doing. Because I had 400 people on my staff. And I would say before we started this work, very few of them knew anything about health equity. They were in traditional positions in the health department, sanitarians, nurse aides, administrators, et cetera, et cetera, et cetera. And I made a decision that we had to find a way to retrain our workforce in this area. So I took a heavy hand, and I admit that to anyone. I required that everybody in the health department had to go through a 6-hour training on social terms of health and health equity that I did myself. So no one could say in the department, I never heard this before, what are you talking about? No, I saw you in the room, I trained you. Now, did that change the world overnight? No, but it was a step in the right direction. Up in Ingham County, Michigan, they use something called the dialogue method, where they, through conversation with each other, they come to the conclusions that are hopefully in the same general direction around equity and social justice, but there are ways to do that. So one of the challenges for you as a health department, as a state health department, is finding ways to re-educate, or to educate in some instances, all those who work for the state health department on these issues. So you have a strong central power of movement to make things happen. You also have an opportunity to work with your local communities to be about organizing for advocacy and work and movement at the local level, so that we get to a place again where social justice and health equity is recognized as the next movement that we are moving through to get things done. We were successful in getting a small grant from the College Foundation to do a racial healing project with our youth in the neighborhoods. The Amen Project was about looking at African American men, particularly those who were formerly incarcerated, but now those who have been out in the community and can't vote. They've lost their privileges as voting individuals because they've had a felony on their record. Photo voice projects. CHI project, which I wanted to mention that in particular. That is a project that we did, if you remember, on unequal treatment, a document that came out several years ago, National Academy of Sciences. Its conclusion was that there were multiple instances and episodes of racism, discrimination, stereotyping throughout the healthcare delivery system. Top to bottom, small, large, state, private, doesn't matter, every one of them. And one of the things that they did was develop an instrument of their own to define and discover those differences. So we worked with this hospital system in our community to come up with an instrument to do the same kind of work locally. That is to look at their own pattern of referrals and see if there's anything consistent in there that says that they're making the referrals all to the right direction, or that in the studies, the chest pain studies that shows that provider bias was involved in making decisions about where somebody goes when they come in with chest pain to a hospital situation. That becomes an extremely critical point. By the way, the policy opportunity here, which is one of my own crazy ideas, is that the Joint Commission on Accreditation of Healthcare Organizations should look at that kind of material in determining if a hospital or a healthcare center gets the stamp of approval. So if I look at your records and it looks like you're, by race or ethnicity, sending patients out of the emergency room or other things that are inconsistent with the right diagnosis, then you don't get a certification from JCO. And if you know anything about a healthcare organization, I just need you to vote in. So the way to do this process, the way to do this work, and this is basic to us, but it's collaborations and partnerships and developing a collective consciousness. Now that does not to say we're a lockstep, we have to say we all walk in the same path, we have the same exact thoughts, but a collective consciousness around this whole notion of justice and equity. And the fact that the fact that there are differences continuing to exist in this country is an injustice. It's a social injustice. So as long as that exists, we're living in an unjust environment. And not just me, who happens to be a black male, or a Latino kid who happens to be a 16-year-old Puerto Rican kid on the streets of the Bronx. Everybody. We're all here in the same system. We're all subject to the same enforcers, but just in slightly different ways. We may not see them, but they're controlling the way we think and the way we react. And I'm saying that part of health equity as a definition is a new vision, a new concept of what the world is all about and what it has to be, and what our part in it has to be to get us there. And we all have an opportunity to be a part of that change. It just means claim it. You know, put that fist up in the air and say, damn it, this is who I am. I'm not going to let this continue anymore. We're going to make this change in this society. There will be health equity and social justice for everybody. So, what do? You have difficult conversations. And they are difficult conversations. They're risky conversations. They're difficult, but they have to happen at all levels of work and life and community involvement. You know, there's so many examples throughout history where populations have died, have been murdered, have been slaughtered, have been left out, have been pushed out, because other people didn't stand up and say, this is wrong, and I'm not going to let this happen anymore. There's so many instances across history, and if you think it can't happen again, just take a look at the daily, gay not being allowed to have their rights. There's so many examples that are negative, but there's a powerful enough force in this country amongst our professionals to make a difference and make this change. But have those difficult conversations. Bring up racism. Say it. Racism still exists. It's not, you know, people often tell me, you know, it's 2015, got a black dude in the White House, you know, post-racial America. No, that's garbage. That's just totally garbage. When you do the analysis, racism exists in every institution in the United States. Every single one, to varying degrees, expressed itself in varying degrees, but it's there. And it's there by virtue of the history of this country. I don't have to imagine anything. If we had time, we could talk about, you know, what has happened for the past 400 years, not only to African Americans, but to Native Americans, and how that has created a climate of racism, looking at other populations as they come into the country or not. So it is an element of society that buttresses the inequities that exist, and we have to work that very difficult process. And part of us is having conversation. The breaking down of silos. I never seen so many silos until I got in academia. I mean, I thought it was bad in public health. But those of you in public health and academia, you had a double whammy. You can't work with the Department of Transportation if you don't break through a silo. And we need that work. You can't work with the Housing Authority to find a way to address a Hope 6 project in your neighborhood without breaking down those silos. You can't talk to the educational system and talk about how important education is to kids, that higher rates of education mean lower rates of infant mortality, a longer life expectancy, and so many other things. You can't talk to those people without breaking down silos. You can't talk to the epidemiology office without breaking down your own silo in maternal and child health, or whatever your particular interest is, because you don't think you can't get outside of this box, and this is the only way that you can operate. We have to be about silo breakdown and say that's a damn good thing. You know what, today, we broke down 17 silos. Oops. Sorry. So it's have difficult conversations. Put fear on the back burner. Tall order, again. Fear is a very powerful force, but so is justice. So we put justice over fear, and justice will win every time. Put fear in the back burner. Don't be bound by the funding issues as they are today. Find other ways to get your funding done. And find ways to get your communities advocating for you and organizing for you and demanding the funding that you need for the things you need to do to the state legislature and the governor's office. You know, anybody's been involved in working with politicians, you have heard them say, if I get 10 emails from this particular issue and this particular people, I'm going to listen to that. What if they got 1,000 emails and said, change the way funding is brought to the communities around the state so we can do work around this, and this? You don't think that would move them to change their vote or to vote in an appropriate fashion? It will, because they know ultimately if they don't follow those 1,000 voices turn to 10,000, 20,000, and they lose their seat, they don't get reelected. It's a very powerful force. So think about advocacy and building opportunities to get this work done. Consider your sandbox. What you do in your playtime when you make little sandcastles and whatnot. This is mine. Let somebody else into the world to be a part of your sandbox. Spread the wealth. Oh, give up control. Oh, I heard two people say, Part of effective leadership is giving up control. It's passing that down to those people who work for you. And then supporting them when they do the right thing and forgive them when they do the wrong thing. But part of leadership is about letting it go. There's also another discussion that you need to have about preparing for the next person to lead. Preparing for, I don't know how you can do that. But that was 23 years. Who's going to take her place and do the work that she's been doing so effectively? So that process of finding the next person and training them well to take over when you leave. Get out of here. Oh, please, move away from your desk. Get out. You may have a challenge. You may have a challenge from your supervisor, unless they get hit in this conversation, to let you get out. But the people are out there. The people that we need to work with, we need to organize around, and we need to connect with, they're out there. Every place I've gone, one of the first things I've always done is to go out and meet with Pastor X and Professor Y and community organizer Z and find out who they are, what their interests are, and what we might be able to do together to move everything forward. So get out of your offices. Those who work in hospital systems, get outside the hospital walls. The hospital has a responsibility to look. It is a part of the community. It has to be a responsible community partner, one that brings something to the table. Jobs, money, influence, support, etc. Get outside of the hospital walls, recognize your role in the community. True leadership is in everybody's grasp. We do some leadership training in Louisville and I'm in Tampa now. In Tampa. Everybody a leader. It doesn't mean that you run an organization. It means you act like a leader in terms of your thought process and your willingness to work with others. Or also, by the way, good leaders are followers. So be about that as well. Let yourself be led. That's a good leadership principle. Take risks. Yes, gotta take a risk. This is risky business. People have lost things by taking risks. They've lost jobs, they've lost money. Sometimes they've lost even more than that. It's the only way we move forward personally, by taking a risk. So take the risk, think differently, think bigger, think movement. That powerful fist. So answer this call to action. Just a few things that we think would be helpful to you to do. Number one, who might you partner with to move your ideas forward? Number two, what are some of the barriers that you may encounter? Number 3, what strategies could you use to overcome these barriers? Number 4, describe what the outcome or product of your applications and strategies toward this issue might look like. Just leave you those 4 challenges and homework assignments for you to take through the rest of the day and the rest of the conference and the rest of your time here in this wonderful state. This was referenced earlier. We found that this series has been shown literally thousands of times across the United States. Every place I go, at least in Jamaica on vacation, every place I go, someone comes to me and says, this is a great piece of work. It really changed the way I see the world. It opened my eyes. We've used this in small community settings. It is an excellent tool for generating discussion around these issues of equity and social justice, etc. It can be done in church groups, it can be done in PTAs, it can be done in your home with 5 of your friends over coffee or tea, or even a drink if you like. It's so powerful. The American Medical Association, the Association of American Medical Colleges, recommended highly that every medical school in the United States use this documentary in the education of its medical students. Now, they can't require it, but they strongly recommended it to every medical school. Every school of public health should be using this. Every school of engineering, every school of nursing, every school of social work. Everybody in college and in the educational process ought to see this material and see how powerful it is and what it might mean in the way they see the world and an opportunity to change the lives of those that they work with. Health and all policies. I know that there's a session today. If not a session, I know I've heard someone talking about it. A critically important next step for many of us, looking at the relationship between other areas that we don't control as public health and finding ways to work with them so every one of them recognizes that the things that they do have public health implications. That new bus route that we talked about, that new housing development, that new school system over here, whatever, that there's a public health issue there. So health and all policies is one way to make us much more available and make those available to make differences in our communities. And remember, all these things are health equity and other issues. Housing policy is a health policy issue. Educational policy is a health issue. Access to health policy issues, access to tobacco, fire, all these things are health policy opportunities that we need to. Now, by the way, part of the challenge then is, what do I know about policy development? What different kind of policies are there? How do I make changes? How do I run this process up through a system locally, nationally, and statewide to make things change? Short-term issues are those things that we do so well in public health, which is to say, let's go set up a new screening program and educate this population over here and see how many of them have diabetes and get them into a system. That's the short-term, that's a downstream policy. Upstream would be the health worker going into a home with his asthma and finding out there's mold and mildew up on the ceiling and having a policy developed that would require the landlord to ameliorate all mold and mildew and roach infestation in his or her properties. That would be an upstream policy-driven process. Just doing downstream policies develops just a healthier underclass. And if that's what you want, then you're not thinking about equity and social justice. A healthier underclass. By the way, we talk, as we mentioned in breakfast, class is an issue here as well. That it's one that we don't want. It's even more difficult to talk about perhaps than race. That there's a class structure in this country that prevents people from moving up and getting things that they need. That's another big question that has to be discussed in your local work. There are lots of examples around the country of people who are doing this kind of exciting work. Kalamazoo, Michigan, where they found a way to send every child who graduates from high school to college for free. The San Francisco Sustainable Health Index, measuring how are you measuring? You're measuring health equity. The Connecticut Health Officers Association Health Equity Index. There's lots of these things that are developing around the country. Portland, which has done a block by block analysis of GIS mapping that's available to anybody. So you can walk into the Portland Health, this office in Portland. I want to see a GIS map to look at nutrition in my neighborhood. And they'll give that to you, and you can use it as a foundation of the work that you might do. Very, very innovative work. Cincinnati has actually started going out and demonstrating in the street. rallies, placards, signs, the whole 9 yards. And so many other things that we could talk about that I would encourage you to take a look at as you go through your work and moving ahead. So are you fired up yet? Let me see the fists for the social justice movement. Matter of fact, turn to the next person next to you and say, you are the movement.
You are the movement.
No, you're not going to say it again.
The movement. You are the movement.
And now, say, I am the movement.
I am the movement.
The quote from Bishop Tutu I'd like to share with you as we close. If we could but recognize our common humanity, that we do belong together, that our destinies are bound up in one another, that we can be free only together, that we can survive only together, that we can be human only together, then a glorious world will come into being where all of us live harmoniously together as members of one family, the human family. And that's the image that I want you to take away. What's the placard say that you're carrying? What does the placard say that you're carrying? This is about building a movement. And there's good evidence as to how it can be done. Focusing on common interests and common needs and making things happen. The gay rights movement, women's movement. As Denise was talking about a bit earlier, what was going on in Indianapolis around that particular set of laws. The civil rights movement itself, the Black Power movement, there's so many examples of positive movements that we can look at to help us to organize our own activities. Movement building is long-term. It's organized groups of people to intentionally spark and sustain a social movement. So this is not something that happens by accident. It's an intentional operation that we move through to make a movement live. Organizing for transformational change, developing collective consciousness, and having a common vision of hope. And finally, it's often easier to become outraged by injustice half a world away than by oppression and discrimination a half a block from home, like outside the walls of the hospital we talked about. And there can be no hope for the spread of freedom, democracy, and human dignity unless we treat health as a basic human right. That's the underpinning of all the work that we do. So, it's over to you. Know what you have to offer and leave here, willing to share beyond your silo. Strive for collective consciousness. See yourself as an engaged community leader. Find political will, which takes courage. Redefine your personal and professional values. Remember, the power of one is real. Remember, this has to be a movement that in fact moves. Be willing to take a risk and ask the tough questions. Now, I'm going to ask you to take a risk right now for me. What I'd like you to do is to take a deep breath. Take a deep breath. Close your eyes. Close your eyes. And just listen for a moment. To laugh is to risk appearing the fool. To weep is to risk being called sentimental. To reach out to another is to risk involvement. To expose feelings is to risk showing your true self. To place your ideas and your dreams before the crowd is to risk their loss. To love is to risk not being loved in return. To live is to risk dying. To hope is to risk despair. To try is to risk failure, but risks must be taken because the greatest hazard in life is to risk nothing. The person who risks nothing, does nothing, has nothing, is nothing, and becomes nothing. He may avoid suffering and sorrow, but he simply cannot learn, feel, change, grow, or love. Chained by his certitude, he is a slave. He has forfeited his freedom. Only the person who risks is true. You can open your eyes. I'll leave you with my dear friend and colleague, Mr. Spark, who said the needs of the many outweigh the needs of the few or the one. So a fist raised to the local movement in Massachusetts. Thank you for your listening to my time. Thank you for the work that you're doing, and I really appreciate who you are. Thank you.
So I'm fired up. I'm ready to go back to the office, roll up my sleeves, and get going. We have a few minutes for questions and answers. There are mics. One there, one over here. Please.
It's about taking risks and building trust with other stakeholders. I'll just put out there the private sector, for example,
Yes.
where bringing them along, educating around equity, and which is a whole new discussion, I think, if I could take a risk in saying that, for the private sector in this work, community development, neighborhood development. And if maybe you could talk a little bit or encourage us to, how do we get over the paranoia and mistrust with that sector to be able to keep going in conversations with them when you kind of feel like you don't totally trust them? And I thought maybe you would have some inspiration for us all with regard to that, critical partnership.
Yeah, I think one of the most important elements of any partnership is the trust and humility and understanding. So what is it that you need to understand about the partner's life, and I don't mean life, that literally what they do, what their work is all about, what their positions are, what their place in community is, and what they might get from this relationship. We, meaning those who do research in this area, have found that sometimes getting involved with the business community is a tough nut to crack, because we come from this from an ethical, moral standpoint, and the business community is more interested in the bottom line. So there's good data out there. If data is your thing, there's good data that says how much does it cost a society to continue to have health inequities. There's something like $1.4 trillion every 16 months from some very basic data looking at direct medical costs, indirect medical costs, and using $50,000 per life, per excess life lost, which is so conservative. But to make sure that they have real numbers that nobody will argue with. And those numbers are now being used to court the business community. Beyond that, I think engaging in open, honest dialogue around these issues is the only way to make things really work. So you take a risk by doing this with this particular partner, but if you approach it with humility, with understanding, knowing what their positions are all about, and a little bit about the business community and the business model, then that may help you with that particular group. Other folk who get the ethical moral issue, it'll be a lot easier to talk to.
My name is Mark Jones. I'm from the Center for Social Innovation. First, I just want to say that I'm really, really happy to hear the word racism said so many times this morning. I'm not originally from Massachusetts. I'm originally from Michigan, and then I lived in New York for 8 years. And I came to Massachusetts and was really astounded by the fact that there were so many racial inequities that people wanted to chalk up to things that weren't racism. So, thank you. And then I also wanted to ask, in terms of having those conversations, right, one of the things that I have been stymied by is how to have those conversations at a community-wide level and thinking about, right, like sort of engaging, and even in sort of the recent months with Black Lives Matter and all that kind of stuff, engaging, white folks in those kinds of conversations has still been difficult.
Yes.
And so I'm wondering if you have any, from your experience or just words of wisdom about how to structure those conversations without losing the word, right? Without having to talk about structural racism or broad inequities, but actually being able to have conversations about racism. Thank you.
There are a couple of models out there that talk about racism on an individual basis, person to person, or person to small group. Of course, one of them was done right here in Boston by Barbara Ferrer and that group, the Boston Public Health Commission, looking at undoing racism in the structure of the health department in Boston. The main model comes from the People's Institute, which is what the Boston people use to create their own, to something that was more organic and fit the local environment. Beyond that, I think you just need to take the risk to have the conversations. I mentioned natural causes, not because I'm in it, but because it's a great tool to get people talking about all of these issues. It's it's just extremely valuable. There's even on the website, on naturalquestions.org, there's even a series of models of how to have the discussion. There's even a question, a survey instrument around health equity that can be used to talk to people, to kind of engage in the conversation about some of these issues.
Hi, good morning. My name is
Good morning.
Andrea Freeman. I'm with the Massachusetts Public Health Association. Thank you so much for your inspiring talk. And I was wondering if you haven't yet run for public office, will you?
Somebody driving in protest over here, my wife. You know, I was asked that question a couple times before, and in Louisville, as we were preparing to depart the city, a couple people asked me, "Would you run for mayor?" I don't think so. But I did promise to show, I wanted to show you, this slide. That's my mother on the left in the chair, and that's Preston next to her. And the other is my mother and my other brother, my middle brother passed away several years ago, so that's our family today. Please recognize my wife, who's telling me not to do that.
Okay, so I think we have a little bit of time, about 5 minutes before we go to, is it lunch? Lunch, okay. So Leah Susan's going to come up and make the announcements. Thank you all.
So we are breaking for lunch. Lunch is in here, and I'm also understanding that MPHA next.